Hi, and welcome back to the NCS podcast Perspective Series. This is Lauren Koffman. I'm a neurointensivist at Temple University in Philadelphia. And today I'd like to welcome onto the podcast authors of the recent NCS Currents article, Transitioning Alteplase to Tenecteplase for Acute Ischemic Stroke. So today I'd like to welcome two pharmacists. We have Gilbert, who's an emergency medicine pharmacist, and Katie Qualls, who's a neurocritical care pharmacist. Both practice at Wesley Medical Center in Wichita, Kansas. Hi, thanks for joining.
Thank you for having us.
Yeah, thanks.
So, before we get into the nitty gritty of, why we need to consider transitioning over the more practical aspects, how do hospitals do it? Can one of you just explain really briefly, like, how does tenecteplase work and why is it different from TPA?
Yeah, I can talk about that. So tenecteplase is a thrombolytic agent. It binds to fibrin-rich clots and then cleaves your bond in the plasminogen to form plasmin. And then plasmin in turn degrades the fibrin-rich matrix of the thrombus. And a couple of the biggest differences between tenecteplase and alteplase is tenecteplase has a higher affinity for the fibrin when compared to alteplase. And then the other one that we really like to talk about is the longer half-life, which gives you the ability to give it as a push dose versus traditional alteplase dosing over an hour.
Okay, yeah, that makes things a lot easier for us when our residents are in the emergency room and scrambling and having to hang things, and then they get moved from one unit to another. Things get lost in transition, so having a push dose is great. So now that we know how it works, the past couple of years, we've had a few different trials that have given evidence as to why we should consider using tenecteplase for acute ischemic stroke patients. Could you just summarize some of the landmark trials?
Yeah, some of the ones that I like to think about are in 2015, you had the ATTEST trial that looked at alteplase standard dose versus 0.25 milligrams per kilogram of tenecteplase. And that was kind of one of the first ones that showed us that there's no difference in radiological outcomes of those. And then you follow that up with your two different NORTEST studies that have just been completed, and then also the Extend IA TNK studies. The first NORTEST study looked at 0.4 milligrams of tenecteplase versus alteplase, and that's the one that showed us that there was similar rate of improvement and the complication rate was also the same in mild or severe stroke. More recently, you had the NORTEST 2 trial, which showed the 0.4 milligrams per kilo yielded a worse safety and functional outcomes. And so kind of when we come to the current dose that we use, the 0.25 milligrams per kilo was really shown proven in the Extend IA trial that showed that it was non-inferior to alteplase. And then when you look at the Extend IA TNK trial, that number 2 that was done in 2019, it still showed no difference between TNK doses when you look at 0.4 versus 0.25. So kind of to round that all out, based on those studies, that's where we have our 0.25 milligrams per kilogram dose of tenecteplase that's most likely used at facilities.
Okay, so you just summarized a few kind of key trials for us. Based on that, do you think we have enough evidence or data to kind of convince people that it's time to make the change?
So I'll take that one. I think we do. At this point, when you consider the amount of patients that have been enrolled in a lot of these trials, it's going to be a lot more robust than other critical care subtypes or patient types that we really see. And so in this setting, I think we do. We obviously haven't hit every single phenotype of stroke that presents to the ER in these studies, but we're also combating this against 20 plus years of alteplase data. And so over time, I believe we're going to see a lot of those subsequent database trials essentially come out and prove overall that there is likely no difference in outcomes or even slightly maybe beneficial in other phenotypes. So I think at this point, we certainly do. So I don't know in terms of efficacy wise if there should be any hesitation for making this switch at this point.
Okay, so thanks. You just kind of covered why we should believe it works. And we touched a little bit about adverse events, but obviously it's a thrombolytic. Most people would be concerned about symptomatic hemorrhage. So what are your thoughts on that?
Yeah, safety profile wise, they do appear to be similar when you're evaluating the 0.25 milligram per kilo dose. The 0.4, I would say at this point, has been established to be somewhat more harmful than the 0.9 milligrams per kilo of alteplase. So I think at this point, I don't foresee a lot of centers utilizing the 0.25 or the 0.4 milligram per kilo dosing. And so, yeah, symptomatic hemorrhage rates are slightly different or with those two dosing schemes, but the one that's going to be utilized should be about the same. The question becomes is how do you manage it, especially with a longer half-life medication? And, obviously there's not enough data out there right now to essentially treat them differently. I think for the most part, most centers would utilize the same protocol that they would use for alteplase. But if you look at that data set, a lot of that is not very robust as it is. And so we don't have a great handle on how to manage that as it is. So probably at this point, we're still going to treat for fibrinogen levels greater than 150 to 200, depending on who you speak with, plus minus the use of antifibrinolytics like TXA or aminocaproic acid, transfusion of platelets if patient has thrombocytopenia. And so there's certainly a lot of data to cover or ways to describe management of TNK associated bleeds that needs to occur over the next few years.
Thanks. I mean, I know at our institution, we essentially have the same reversal protocol for the tenecteplase that we were using for alteplase. Are you doing the same practice?
I'm not sure we've had a TNK since our switch. I'm not sure we've had a TNK associated bleed yet, but for all intents and purposes, we would treat it the same. Just speaking with our intensivist and our emergency medicine physicians, I think that's what we would do. And you kind of get stuck in those no man land of where you have those bleeds that are 4 to 6 hours out, and you wonder if there's any associated hyperfibrinolytic activity still occurring. So I've always been a proponent of utilizing thromboelastography to check and see before we erroneously give antifibrinolytics. And obviously we have fairly robust thresholds for fibrinogen values. But yeah, it's certainly a conversation that or data sets that we need. So if people have this data, we need to make sure that we're publishing that so that we can try to develop the best protocols.
Yeah, that's a really great opportunity for us to keep eyes open for in the future. So you mentioned you've been using this. We recently switched over a few months ago. When did your institution make the change? And are there any learning points you guys have had through your experience?
Yeah, we decided to make the change in August of 2022. So we've been doing it for a little bit over a year here at Wesley. And I think one of our biggest learning points that we learned before we started was really getting everybody on board. I think that that's one of the most important things, is to make sure that all your stakeholders are available and willing to make the change. I think getting all of our providers and whether that's emergency medicine, neurointensivists, or our neurology providers all kind of together to know, hey, we're making this change. But then also thinking through how are we going to educate all of our nursing colleagues and anybody that's going to take care of these patients that's kind of outside of that realm. I think that was one of our biggest areas that we when we made the change, was making sure that we had thorough education to anybody that's going to be involved in the process, because it is different dosing. And when you look at fibrinolytics, you have different indications for different medications. So really making sure that you know what you're using tenecteplase for, and if you're keeping alteplase on formulary, what that's going to be used for as well.
Okay, so you mentioned education. What's one thing to consider when transitioning, but I think there are also some kind of financial implications as well.
Yes. When thinking about the financial implications, the cost of tenecteplase is lower than that of alteplase. And so that was one of the other driving factors, is looking at the cost reduction that you can do with it as well. When you look at the Extend IA TNK trial, I thought it was pretty interesting that they had a secondary analysis, I believe, that looked at the cost per hospitalization. And so when you use the tenecteplase versus alteplase, your tenecteplase hospitalization was $22,000 around, versus your alteplase was $29,000. So while that people may not think that that's that significant for some hospital systems, and when you're looking at the number of cases, that can be a very substantial number.
For sure. So kind of following up on the education that you said that is needed, I thought it was really interesting. In your currents article, you discussed considering having a stroke kit available. Would one of you just walk us through what's in that kit?
Yeah, I'd be happy to. I just used it probably an hour ago. So the reason that we utilize a physical stroke kit is that for those who haven't actually laid eyes on the TNK box is that it actually comes in a box that has myocardial infarction dosing in it. So to try to mitigate any adverse effects or dosing errors, we physically removed the product and the diluent itself away from the package itself. And so we developed this kit as a way to, one, prevent those errors from occurring, but then also to have everything that a pharmacist, a nurse, physician, or whoever is admixing the medication to have it ready. So our kits actually have the drug, the diluent, any of the subsequent supplies that you would need, like needle bevels, alcohol swabs, and syringes available. And then the other thing that we developed was essentially a dosing sheet and dosing card, which is also, I believe, available on that current article, just as a way to make, again, that dosing easier and to have essentially two sets of eyes evaluate so that we don't end up with any of those errors. And so it's been really valuable for us. As a center that's still utilizing alteplase for pulmonary embolism as a way to try to, again, mitigate those adverse events, and while also maintaining appropriate door-to-needle times.
Okay, thank you. So now I know we keep referring to your current article. There is a super helpful checklist that you have included in it. We will include a link to this in the show notes. But are there any key or most important points you kind of want to highlight from that checklist for the listeners?
One thing I thought was key when you're doing this and going through is making sure you have all the parties available that are going to be mitigating the change. When it comes to safety, I think a lot of our agents, when we use thrombolytics, are in our automated dispensing cabinets. And so really assessing who can get to what. I know sometimes in different emergency departments, your level of override capabilities can be different. So who is going to be able to override these user access, and then also making sure whoever is accessing it, have they had the appropriate education regarding how you dilute it and mix it and dose it. And then other things to consider is, unlike alteplase, tenecteplase is a push dose. So once you give it, it's in. So really making sure that your blood pressure parameters and those things are also being quickly monitored after and during the push, where you're making sure that you're looking at that and making sure our nursing colleagues are really helping assess that, as well as talking to providers. And then we kind of talked about our kit and our operational and preparation of that and how that's important. And then other things to consider is looking at the cost and the billing practices within the finance department. So really reviewing that to make sure that when you make the switch, you are getting the most advantageous for that. And then making sure that it's built appropriately in your electronic medical record system to appropriately bill in different instances.
Great. So now, I mean, you guys have kind of explained why it works, how it works, and why there can be financial incentives to make the transition. So why do you think some centers are still hesitant to kind of make the transition over from alteplase to tenecteplase?
I think there's probably a lot of factors that go into that decision. We really didn't have a lot of hesitancy at first. Where I wouldn't say we were an early adopter, but I would say we're somewhere in between the middle and early adopting. And some of the things that we were concerned about was, obviously, with that longer half-life, is as soon as you push that medication, there's no getting it back. So we wanted to make sure we had our ducks in a row in terms of the safety protocols, but also the safety data that was available. We didn't want to be surprised with a safety outcome that came out later with some of these larger trials that Katie had recently quoted. So I think that was one of the biggest issues we were considering at first, was the safety aspect. Another would be some of the operational considerations. So one thing we haven't really touched on today was that TNK itself, you're not able to pre-mix this medication. Currently, at the time of this recording, Genentech does not allow for vial replacement of this once it has been mixed, if it's not used. And so I know that that's a practice that occurs with a lot of centers to try to reduce door-to-needle times. But when you look at the other operational factors of TNK, being able to just push the med and give it right away certainly doesn't slow down a lot of time. And so that pre-mixing process really, I think, is negated by the ability to push and not need a pump and set everything up. And then I think, the other thing would be just hesitancy of, we have 20 plus years of data with alteplase. And so some of that hesitancy, and anytime there's a big change or any sort of practice that is going to be new, and from sort of the dogma of what we've had for neurocritical care, it's going to be met with some resistance at first. And so I think that's probably some of the issues we've had, and trying to identify if TNK should be used for all strokes or just certain phenotypes. And I think now we have enough data, as we previously discussed, to make the switch over for all. But I could see that being some of the hesitancy.
Well, thanks. So I guess I'd like to ask if there's any last pieces of advice, especially if you're trying to convince someone to make the transition.
Katie, you want to go first, or me? Or
you can go first.
Okay. I think initially, I think having a initial meeting with all parties that would be involved, and then breaking out into subgroups instead of having really like a large meeting for every single process change. I think that if you divide and conquer, it becomes a lot easier, especially for a large institution that's going to have a lot of different opinions on it. I think for your moderate sized institution or community-based institutions, it may be slightly easier because there's only going to probably be a few parties involved, that as opposed to a plethora at an academic center. But I think that would be something I would consider first, is one big meeting to start, but then breaking up into subgroups and making sure that there is one distinct leader that is sort of pushing the process through and finding those updates.
I think that's good at a facility level. I think one other thing that I didn't really consider in the beginning that I wish that I would have thought about more was, if you are a large referral center, is what are the facilities around you doing? Because I think that we talk, when you talk to different facilities, especially as providers, it's, well, what are you doing? We're doing this, and kind of really getting them on the same page. I think that helps coordinate care, especially when we have so many transfers in that have gotten thrombolytic therapy. So maybe reaching out and having those relationships and those conversations early, especially with, I know there's a lot of littler facilities that are out there that are going to start only using maybe one thrombolytic agent and have one available. So knowing that, and knowing how to best, guide them in their quest before the patient get to you as their final destination or whatnot.
Well, thanks so much. I appreciate you joining. We'll include a link to the article in the show notes, but to check out this or other Currents content, please go to currents.neurocriticalcare.org. As a reminder, NCS offers free CME for listening to select episodes. Listen via the NCS Learning Center and complete a short survey to receive your free credits. Otherwise, you can access the NCS podcast wherever you get your pods. Don't forget to add us to your favorites, and be sure to never miss an episode.